channel Cancer Reach. Cancer Reach is an initiative by our very own doctor, Dr. Krishnamani, to spread awareness about cancer and help patients and caregivers to access the right treatment at the right time. Our theme today is Shining a Light on CML. Awareness Saves Lives. Chronic myeloid leukemia or CML is a type of blood cancer that has seen tremendous progress in treatment over the past 2 decades. What was once considered a life threatening illness can now often be managed as a chronic condition, but only if it is diagnosed early and treated appropriately. The goal of this session is to spread awareness, answer important questions, and empower patients, caregivers, and the public with the right knowledge. Joining us today is Dr. Krishnamani, one of the most respected voices in the field of oncology. For over a decade, he has been a key pillar at AOI hospitals here in Hyderabad, where he specializes in the treatment of solid tumors, blood cancers, and oncological emergencies. With prestigious international fellowships and leadership positions across some of the India's top cancer centers, Dr. Krishnamani combines deep clinical expertise with a truly global perspective on cancer care. His contribution extend beyond the hospital walls, shaping cancer care policies, advancing treatment protocols, and driving impactful research. Hello and welcome to you, sir.
Hello, everyone. Welcome to Cancer Reach. Cancer Reach is an initiative to spread awareness about cancer. And as you very beautifully put, today we are talking on CML, and you've actually summarized everything in a span of 30-40 seconds about the journey of CML or chronic myeloid leukemia.
So, sir, can you begin by explaining what is the condition mainly about chronic myeloid leukemia?
Chronic myeloid leukemia. C for chronic. Chronic means it has been there for quite some time, longer duration. Acute in medical means it's a shorter duration. So chronic means this process has been taking some time to develop. Myeloid is a type of WBC. Lymphoid is another type of WBC. Leukemia is blood cancer. So blood cancer, which affects the myeloid part of the WBC, which is chronic, which has been there for quite some time. That is chronic myeloid leukemia. So whenever something chronic is there in your body, you will not develop symptoms instantly. Okay. So things develop over a period of time. Acute means acute myeloid leukemia, for example, blood cancer which starts instantly or very, very short period. Then the patients are very symptomatic. Here what happens? The body also gets time to adjust. The WBC count in the body becomes very high. But all those WBCs are bad WBCs. They are at different phases. So basically a WBC also goes through a phase of maturation, we say. Okay, like a promyelocyte, myelocyte, metamyelocyte. These are the types of WBCs. The earliest great grandfather, father, son, if you have to put it very simply. So normally what happens, you have high neutrophils, which is 60-70%, 20-25% lymphocytes. This is the normal WBC structure. And the normal WBC count is between 4,000 to 10,000 or 11,000. So if we have a WBC count, we'll have 4,000 to 11,000 is a normal range, in which 50-60% are neutrophils, 20-30% are lymphocytes. You don't see these precursor forms. Now, if your WBC is 1 lakh, 1,50,000, and you see neutrophils, lymphocytes, promyelocytes, myelocytes, metamyelocytes, basophils, that means the entire spectrum of WBC is being seen. That neutrophil lymphocyte ratio is completely dismantled. You are seeing earlier forms also, and the WBC count is extremely high. This is a classical chronic myeloid leukemia. And then you also see some bad cells called blast cells. If your blast cells are less than 10% or 10 to 20% or more than 20%, you divide the chronic myeloid leukemia into CP, AP, BC. CP means chronic phase. That is the initial stage where the blasts are less than 10%. Accelerated phase is the next phase. When you have chronic phase and you're not treated them for some time, they go into accelerated phase. Blasts become more, 10 to 20%. And if the blasts become more than 20%, you become a leukemia. That is called blast crisis. They are treated like an acute leukemia. So to put it simple, it's a blood cancer of the WBC, which has been there for quite some time, where the WBCs are very high and all the phases of the WBC are seen.
What would be some of the early signs and symptoms related to this disease?
Most of the time, you go for a routine checkup, you may find a very high WBC with this kind of a picture. Some other signs may be fatigue, non-specific symptoms, extreme weakness, low-grade fever, pain in the left side of the abdomen, or a bulky feeling there. That is because the spleen becomes very big. Normally, your spleen is under the ribs. If the spleen becomes much bigger, what happens is you develop discomfort on the left side. You have some pain, you have some heaviness. That is called splenomegaly. Megaly means increase. Spleno means spleen is increasing. So you may have low-grade fever, non-specific symptoms, weight loss, fatigue, weakness, loss of appetite. This splenomegaly, because of the splenomegaly, you may have pain, you may have early satiety. You eat a little, you feel a sense of fullness. And if the disease becomes very severe, your platelets will go down. You may develop small red spots called petechiae over the skin. You may have bleeding, or your hemoglobin may become low. You may have breathlessness while walking, severe anemia. You may have bone pains. These are all in severe phases. But mostly today, CML is picked up incidentally. They go for something, they get it done, or they have some basic symptoms. If you do a blood work, it will throw up a diagnosis like CML.
So, like, how would you describe the incidence of CML? Like, is it the disease burden is more in India as compared to the global rates, whether it is more in the older adults or in the younger population?
It's see, the disease incidence probably is the same because of our population. Our we see a large number of cases, and it's a disease which is seen above 50 years. You'd also see it in the 30 to 50 age group. There is a set of CML called the pediatric or the teen and young adolescent CMLs, which we see below 18 years, in 13 to 18-year group. So it is seen in all the age groups, but obviously predominantly people above 40 or 50 years.
So, when you talk about the diagnosis, is it going to be different from diagnosing any other type of blood cancer?
See, understand, CML is caused due to a particular problem. There are two chromosomes, 9th and 22nd. They exchange certain material that produces a protein that is responsible for the blood cells, bad blood cells, or the immature blood cells. So CML is primarily due to a translocation between 9th and 22nd. Translocation is transfer of certain material which forms a protein called BCR-ABL protein. BCR-ABL protein, which causes the whole problem. So this was a landmark breakthrough in cancer where they identified a mutation because of exchange between two chromosomes as the reason for a cancer. And then what happened? Once you have a target, you have a medicine. So people started researching a medicine and they made a molecule which will block this translocation or this mutation. So when the mutation is itself not there, when the translocation is not happening, or when the protein is not there, everything is set into order. So all the immature cells become mature cells, or it becomes normal neutrophil lymphocyte. So 25 years back, we identified CML looking at high WBC count and the all the immature cells being. Then 10, 15 years back or 20 years back, people realized, okay, this is because of a BCR-ABL protein. Then the first set of drugs came into the market, TKI, as we always say, tyrosine kinase inhibitors, which are tablets. So these are small molecule medicines which block the BCR-ABL. So it reverses the problem completely. So your WBC count is normal. So what we superficially see as a very high WBC count internally is due to a translocation 922 BCR-ABL protein.
So besides this one test, are there any other tests also which the patients will be advised to take?
So, as we always discuss, we will do tests to confirm the diagnosis, which is either a bone marrow or a flow cytometry, or on peripheral blood, we say on blood or on bone marrow. We will do BCR-ABL by, you'll do FISH for cytogenetics. FISH, we call it FISH test for cytogenetics, BCR-ABL by RT-PCR. So you have to do 920, you have to see the BCR-ABL protein to call it CML. Okay. And that is number one. So you confirm the diagnosis. Then additional tests are your complete blood picture, kidney function, liver function, to see the general health of a patient. You may do certain additional tests in the form of LDH, etc. But for diagnosis, BCR-ABL is a must.
So how has the treatment been previously and how is the treatment now for the CML patients?
So some 35, 40 years back, there was a drug called interferon, which was used for CML. It was very toxic, a lot of side effects. Interferon is still the drug which you can give in pregnancy in CML. And beyond interferon, patients progressed. CP became accelerated became blast phase. Overall, patients used to die within CP to BC, they will reach in 5 years or so. And once you develop blast crisis, survival is less than 6 months. So within 5 to 6 years, the patient will go from one end of the spectrum to another. Interferons were used. There was a drug called hydroxyurea. They were used. Other chemotherapeutic drugs were used. And finally, transplant was being done for these patients, saying that transplant is the only way to cure you and all that. Today, last close to 22 years, there is a drug called imatinib. That was the first medicine approved for CML. Imatinib. It targets the BCR-ABL kinase protein. After imatinib, second generation, this is the first generation, like your iPhone 5, iPhone 10. Then your second generation TKIs came, dasatinib, nilotinib, bosutinib. Then your third generation came, ponatinib, etc. So today, CML, you hardly use interferon. Very, very, very few patients are needing transplants. The treatment of choice is TKI, either first generation imatinib or its brothers and sisters, second generation dasatinib, nilotinib, etc. These are taken, they attack the BCR-ABL domain, the entire maturation process is set into motion, the WBC count recovers, and the patient is fine. These are tablets taken at home. But you come to the hospital every 1 or 3 months with blood checks and other monitoring requirements, which we will talk.
So for how long are these TKIs given to the patients?
So before going for how long, you should understand how are you going to assess whether it is working or not. So how will I know if you have taken Dolo is working or not? Your fever is disappeared. So how will I know if imatinib is working? Your WBC count becomes normal. So earlier we used to be very happy. Within 15 days, WBC will become normal. 1,50,000 WBC will become 11,000. Neutrophils, lymphocytes become normal. All the metamyelocytes disappear. We were very happy. Then science advanced. This is called hematological remission. That is, WBC count is becoming normal. Then we realized patients were coming back with relapse. Imatinib is not working. Or we also realized that just seeing a blood test is not enough to say things are fine, because it's a molecular problem. Then we started looking at cytogenetics. We were doing bone marrow and seeing how much percentage of that 922 translocation has come down. That is called cytogenetic response. Okay, for complete cytogenetic response means no metaphases of 922 are seen. Minor or partial means 1 to 35. Minor means 35 to 65% is still seen. So your blood may become normal, but underlying still lot of metaphases are there. That means this fellow will relapse tomorrow. Got it? Then we realized beyond cytogenetics, there is molecular. That is, look at that BCR-ABL. So if the BCR-ABL protein comes down significantly, you call it molecular remission. So today you have guidelines to tell you, if you are on imatinib or any of these medicines, in 15 days to 1 month, you should achieve hematological remission. So in 15 days to 1 month, call your patient, your WBC count, your neutrophils, lymphocytes should become normal. Then you will say, boss, first step achieved. Your medicine has started working. You have achieved hematological remission. In third month, you will do the BCR-ABL. Your BCR-ABL should be less than 10. In sixth month, it should be less than 1. Remove 1 0. In 12th month, it should be less than 0.1. That is MMR, we say, major molecular remission. So suppose at 1 year, somebody has achieved MMR, that is BCR-ABL less than 0.1. That means molecular level of disease eradication has happened. So you will take the tablet daily. First 1 month, you will just get the CBC and show. Third month, sixth month, 12th month, on the blood, they will do a BCR-ABL test. Cost hardly 2,000 rupees to 2,500. Third month, you should have less than 10%. Sixth month, less than 1%. 12th month, 10, 1.1. Remember like that. You have achieved MMR. MMR means you have gone to the depth and killed the cell. Now continue the drug. Ideally, keep continuing. If you have toxicity or you don't want to take the drug or some cost issues, imatinib is hardly 1,500 rupees today per month. Many times we even give it free of cost through some agencies. Dasatinib, nilotinib may cost you between 7 to 10,000 a month. Imagine you cannot afford. After 3-4 years, you have to stop. We do stop. For whom? You have been in MMR for 3 years. You are constantly taking the drug. You have some life-threatening side effects because of this drug. That's why you are not able to continue or you don't want to continue. Beyond MMR, we go for something called MMR 4.5. That is not only less than 0.1, it should be less than 0.0032. Imagine how much deep you are going into the response. So if somebody has achieved MMR 4.5, that is less than 0.0032 BCR-ABL, been using it for 3-4 years, then you can think of stopping, but keep doing the BCR-ABL. If it increases, restart the drug. But otherwise, generally you say, boss, blood cancer, you are taking one tablet, you are doing so well, why don't you continue? And you will not believe, trust me, today many doctors have CML patients who have been surviving for more than 20 years with excellent quality of life. They're working, they're doing their job, they're just taking a pill. They just do this test once in 6 months or once in a year now and come and show. So excellent. This drug has changed the face of oncology.
So, irrespective of the age group that a patient belongs to, that patient will be prescribed a TKI only for
Yes.
CML.
Except when you're pregnant, I think TKI should not be given in the first trimester. You are given interferons.
Okay, okay. So, sir, what about the quality of life of these patients? Like when they are when they are diagnosed, when they are on the TKIs?
They may have some dry skin, swelling around the eyes, swelling in the ankles, fair skin. They become very fair. So that's why I sometimes joke to my patients and say, somebody who's dark like me, you take taking imatinib, you'll become very fair. You don't need a fair and lovely. Okay. So sometimes wives come and complain, sir, pura safed ho gaye. I say, be happy. He's become lighter in color. But anyway, that causes depigmentation. So sometimes you can have hypo or hyperpigmentation. So fair skin, dry skin, periorbital edema, swelling around the eyes, swelling around the ankles, bone pains. These are all common. Nilotinib is one drug which can cause some heart problems. Dasatinib is one drug which can cause fluid around the lung accumulation. Fluid around the lungs called pleural effusion. So these are the common side effects. Otherwise, fairly well tolerated. And you don't need to come to hospital, no chemotherapy, no hair fall. no mouth ulcers, none of those kind of problems. You need to do regular CBCs, do regular ECGs once in 3 months or so, look at your electrolytes, sodium, potassium. That should be fine.
What are the lifestyle or the dietary changes that you advise your patients who are diagnosed with CML?
Not much. Healthy diet, have a balanced diet, fruits, vegetables, probably reduce a little bit of salt in your diet. If you're using nilotinib, you may have risk factors for heart. So reduce salt, keep your blood pressure under control. If you're dasatinib, if you're breathless, just get a check done whether you have some water around your lungs and all that. So otherwise, dietary restriction per se nil.
Okay. So, can CML patients lead a normal life, including the work aspect, the travel, family planning? In all those aspects, they will have a normal life.
We have a patient. I always give the example of the patient. My teacher was treating her from 94. She was a teenager back then. So she has seen the evolution of CML completely. So she was put on interferon, she was put on hydroxyurea, and then the first trial of imatinib was done at our institute, and she was part of the trial. She was on imatinib for a few years, then she went for dasatinib. Today she's on nilotinib. Close to 30, 31 years she's been surviving with CML, and she's close to 48, 49 today. Even last week, I think she went on a pilgrimage and she came. She's perfectly fine. Uh, so what I'm trying to tell you is, and most patients are like that. She's one of the patients whom we have such a long follow up. But most patients lead a good quality of life. They're able to travel, and so it is okay.
So, are there any, like, if you were to say it in percentage form, how many patients would experience a relapse of the CML disease?
Don't percentage wise, I don't know. I'm not sure if my number is right. But relapse means, see, some relapse is because relapse happens, yes, commonly. If you that is why we change from first generation to second generation TKIs, and then so suppose somebody is using imatinib, if so, then we put them on the dasatinib and nilotinib. Understand what does relapse mean? We have to understand. If you are not reaching your target endpoint, if at 1 year I am not reaching MMR, that means I have to change. So it is not relapse like in the sense of another cancer, but here it is different. You don't meet your endpoint. That means you have to change the therapy. That occurs in a significant portion of patients. And more importantly, I would want to highlight for the sake of our patients, we will at that time check for something called a kinase mutation. There is one particular mutation called T315I. We do the blood test. Suppose you are using nilotinib. Nowadays, we use second generation also in the first, before imatinib, without using imatinib also. That is also, so today, for a patient who comes new to you, you can either use imatinib or dasa or nilotinib. Any of the things are okay. Imagine, so somebody who wants a better response can go for dasatinib rather than imatinib. Suppose you have used dasatinib. 1.5 years later, this patient has progressed. You're going to say, I gave the best drug to you, but you still have progressed. So you will, in the blood, check for kinase mutation. If you have T315I positive, this patient will directly go on a drug called ponatinib. If it is T315I negative, from dasatinib you can go to nilotinib or bosutinib, etc. For T315I, nothing works, only ponatinib. So that one thing our patient should understand. When you progress, get a, like how we see in other cancers, when you progress, get a biopsy done to confirm the diagnosis. Here, when you progress, get a T315I done.
Okay. So what message would you like to give to the patients, their caregivers, and the general public for CML awareness? Since this session is specifically for CML awareness.
Treatable disease, very much manageable disease, minimal toxicity, simplicity of treatment in the form of tablets, simplicity of evaluation in the form of basic blood tests, inexpensive mostly. Drug hardly costs 2,000. Imatinib, dasatinib is between 7 to 10,000. India is one of the cheapest markets in the world where you get these drugs so dead cheap. In the West, they're in thousands of dollars. Access is so easy. So many centers of cancer care where you can go and show. Highly treatable, highly controllable. Quality of life is excellent. So don't worry. Be under regular
Okay.
follow-up.
Sir, a few lines about the second opinion campaign that you are running on your own.
So we are having a second opinion campaign. Patients in remote areas can get to us on WhatsApp, send us those reports. We'll give them a feedback free. This is just to give them a sense of direction where they don't have an oncologist nearby. They're free to go wherever they want. This is because they are at sea most of the times. So at least to tell them that this is this stage and these are the tests they have to do further, like a biopsy or a scan, etc.
Thank you for this session on CML awareness, and we hope to see you again next Friday with another important topic and another informative session.
Thank
Thank
you.
you for your time, sir. Thank you.